I'm going to be talking about inflammatory myopathies, and you guys can all see the slides, right?
Yeah, we can see the slides.
Okay, great. So this is just going to be an overview for inflammatory myopathies. There's many diseases associated with this. I'm going to try to focus on the boards as well as the floors that you guys, and if you're combine the clinic, you guys will see a lot of this. There's a good deal in our patient population here on the west side, at least if not throughout the city. So these are just some things to look out for, and what kinds of questions to ask your patients to assess them. So just as an overview, there are many different categories of myositis, from dermatomyositis, polymyositis, inclusion body myositis, immune-mediated necrotizing myopathy, myositis of antisynthetase syndrome, and myositis with overlapping syndrome. These are the broad categories that we know about so far, and I'm going to touch base on most of them individually to give you a sense of how to differentiate and what to look for. Of course, there's also a differential for myositis. A lot of these differentials are within the spectrum of rheumatology, but some are not. And it's important to exclude these other causes, as the treatments are varied, if not different. And there can also be overlap. So you can see here, for example, polymyalgia rheumatica and sarcoid myopathy are autoimmune diseases or rheumatologic conditions, but there are also hematologic causes such as amyloid or paraneoplastic causes, endocrine disease, which may overlap with autoimmune disease, especially such as thyroid disease or thyroid autoimmune disease, diabetes, diabetic amyotrophy, and this sometimes shows up on the boards. So it's important to differentiate. Neurologic causes are important also. You'll see that we often work hand in hand with the neurologist, try and differentiate metabolic or genetic causes of motor weakness. Drug-induced causes, you can see a lot of these drugs are actually used to treat rheumatologic conditions. So sometimes it's a bit challenging for us to try to figure out if the steroid is treating the myositis or is it actually causing a myopathy or causing a secondary myopathy. Or even colchicine, for example, which we often use for things like pericarditis or gout even, and as a potential cause of myopathy. So these are things to look for. And chemotherapy checkpoint inhibitors, which is something within the last few years that's really come to light in terms of secondary autoimmune manifestation of chemotherapy checkpoint inhibitor use as side effects causing myopathies. Rhabdo is important to differentiate, especially when CKs can be very high. It can be challenging and tricky, but there's ways to differentiate that also, and infections such as HIV. So what is the classic typical presentation of myositis? Progressive muscle weakness. Weakness is the key word here, which is different from other kinds of arthritis that we often see. For example, polymyalgia rheumatica is more stiffness or pain. Histologic findings of inflammatory cell infiltrate, which is seen almost with all of the myositis except for inclusion body. And the other things to look for is in history and exam, which are very important. Serologies, which I'll go into to sort of give you an overview of why we rely on different blood tests to check for markers of antibodies that help differentiate the types of myositis, imaging and EMG studies, and muscle biopsies. So the first myositis we're going to talk about is dermatomyositis. On H&P, the key finding is symmetric muscle weakness. The key differentiating factor between dermatomyositis and polymyositis is skin findings, which we'll go into. But sometimes you can diagnose dermatomyositis simply based on the skin findings. And in some cases, you'll see the skin findings come first before muscle weakness. Preceding the diagnosis of muscle weakness. We had one case where the patient was actually seen in dermatology clinic with characteristic dermatomyositis rashes with a biopsy that confirmed an inflammatory infiltrate, and they didn't actually have motor weakness yet. And in that case, you have to think about clinically amyopathic dermatomyositis or CADM, CADM. And so that falls under this category as well. The labs to look for typically are an elevated CK or muscle enzymes. The ANA may or may not be positive, which is tricky. Just because an ANA is negative doesn't mean you've ruled out myositis. do remember that and do understand that as a key. And there are these other dermatomyositis-specific antibodies, such as anti-MI2, anti-MDA5, and anti-TIF1 gamma. Just briefly touching on this here and then again later, that each of these individual antibodies also have certain associations. For example, MI2 is associated with acute onset dermatomyositis, MDA5 associated with ILD, and TIF1 gamma associated with increased risk of cancer. So how to differentiate dermato from other types of myositis, the pathology and biopsy are very helpful. You can see here in this image, there's a perifascicular or perimysial inflammatory cell infiltrate with mostly CD4 positive staining and vasculopathy with injury to the capillaries. These are the characteristic skin findings I was mentioning, including Gottron papules over the knuckles, periungual capillary changes, nail fold changes, which may be visible grossly on capillaroscopy, which we can carry around in the office, as well as calcinosis cutis, which is skin changes at the tips of the fingers. These are some more rashes you may see on the extensor surfaces, including the thighs, which is called Holster sign, which I'll also show a picture of later. Facial rashes, which are oftentimes photosensitive, or V-neck shawl sign rashes. This is a typical classic board question where they show you the rashes and give you a clinical scenario of muscle weakness, and then they ask you a secondary question based on the diagnosis of dermatomyositis. We've also had some cases in-house, so many of you may have come across this based on the recent consults that we've received in the last couple of months. So clinically amyopathic dermatomyositis, as I mentioned, is the cutaneous finding classic for dermato, but these patients actually have normal or subclinical motor weakness or a normal CK, which, as you can imagine, is tricky when you're saying somebody has myositis, but they don't have motor weakness. But it has the same characteristic rashes, and there is still a big risk for malignancy and pulmonary disease. So these are things to look out for, screen for, and treat the patient for, and not to ignore. Polymyositis is the second category of myositis. This again has symmetric proximal muscle weakness, but there's no skin findings, which differentiates it from dermatomyositis. Again, the labs are an elevated CK and muscle enzymes and plus or minus an ANA. And here the pathology is classically different. So this is the board question to differentiate dermato from polymyositis, is that the infiltrate here is endomysial within the muscle fascicles rather than perimysial, and the inflammatory infiltrate invades the muscle fibers. The staining is also CD8 positive here, whereas in dermatomyositis it's CD4 positive. Therefore, you kind of can get a sense here that when the case is challenging, where a patient may not have obvious rashes yet, but has some weakness of the muscles, and maybe some vague antibodies or elevated CK, you're not sure what they have, it can be helpful to get a muscle biopsy early on. The third category of myositis is immune-mediated necrotizing myopathy, or IMNM. This resembles polymyositis with the same proximal muscle weakness, but it's here the key difference is that there is no inflammatory cell infiltrate on muscle biopsy. And this is most classically seen with two key points that you can gather from the history. One is statin use, which, as we know, a lot of our patients are on statins for other reasons. And here you can check for a specific antibody to something called anti-3-hydroxy-3-methylglutaryl coenzyme A reductase, or HMG-CoA reductase antibody, which is a send-out lab, and with a history of statin use. Now, the antibody is not always positive to confirm this diagnosis, which is why a muscle biopsy helps, and giving the history to the pathologist and doing the MedRec. Of note, just so you know, statin use myopathy doesn't have to be myositis. It could range anywhere from simple myalgias, muscle cramps, to gross myositis and motor weakness with positive pathologic findings. Also of note, statin myopathy or myositis can occur with immediate use of the statin, or can occur anywhere from months to years on after continued use of a statin. So temporal association has not been established in these cases, and it can be tricky. The other type of immune-mediated necrotizing myopathy is associated with the anti-signal recognition particle antibody. This is also a send-out test that is available. Now, immune-mediated necrotizing myopathy is a little different from dermato and polymyositis in terms of clinical manifestation, in that these patients really have severe disease compared with the others, with very high CK levels. And typically this pathology is difficult to control despite the use of immunomodulator or steroid or immunosuppressant treatment. And the pathology, like I mentioned, doesn't have the inflammatory cell infiltrate, but it has a lot of necrosis of the muscle, which is basically irreversible. Inclusion by body myositis is the next category of myositis we're going to talk about. This typically occurs in an older age population, mostly males, and has more of an insidious onset or slower progression of disease, which can go on for years before patients are diagnosed. Interestingly, also, this compares to the other myositis in that there's more distal rather than proximal weakness, particularly involving the finger extensors and the forearms, whereas, as I mentioned, for dermato and polymyositis, it usually involves the proximal shoulder muscles as well as the proximal hip and buttock muscles. Here, also differentiating this category of myositis from the others is that the CK levels can actually be normal, which can be misleading, and also why you can imagine it's harder to diagnose sometimes because of the different features of involvement of the muscles, the slower progressive insidious onset, as well as normal muscle enzymes. Again, pathology and biopsy is very important. Here, the inflammatory cell infiltrate is endomysial, and the key board question here would be something called rim vacuoles or inclusions, you can see on the right slide, with Congo red staining. If you have a suspicion of this, you definitely want to discuss the case with a pathologist if it's stumping you and you're not sure what could be going on. So here's just a brief comparison. You can see what I was explaining here in terms of the extensor muscles being involved in the finger flexor muscles here in the picture on the bottom right, that these patients have severe atrophy of their hamstrings, as well as you can see their arms are basically, their forearm muscles are basically atrophied, with resulting deformities of the extensors of the hands and flexors of the hands. These patients, just to compare briefly between polymyositis and inclusion body myositis, are usually males, are much older, slowly progressive insidious onset, as I said, with a normal or low CK. The pathology and the EMG studies are different, and the treatment response, unfortunately, with IBM is very poor. Despite using immunosuppressants or steroids, these patients generally don't regain their muscle strength as dramatically with treatment compared to polymyositis or dermatomyositis. The next category of myositis is antisynthetase syndrome. On history and exam, the key feature here is not only do they have myositis, but they also have extramuscular findings. The typical extramuscular findings to look for are interstitial lung disease, which you can see on the bottom most right picture, which can be seen on CAT scans, and questioning symptomatic findings of shortness of breath, dyspnea exertion, functional capacity, exercise tolerance, pulmonary function test, having pulmonologists on board. Sometimes, by the way, chest x-ray and CAT scan findings may detect underlying interstitial lung disease even before a patient is symptomatic. And there's some recent data in the rheumatologic and pulmonary worlds of trying to screen early on, even when a patient may not be complaining, because it may pick up interstitial lung disease early on in patients with these conditions. The second issue that you see in antisynthetase syndrome is mechanics hands. You can see the third picture here with a roughening of the skin, maybe puffy fingers, some arthritis or stiffness of the knuckles. The third issue is Raynaud's, which is the second picture you can see here, which is a red-white classic definition of red-white blue discoloration of the fingertips, the distal hands and feet or ears, possibly on exposure to cold due to a lack of circulation and vasoconstriction of the vessels, which shouldn't occur normally. And the other thing here on the initial picture here is you can see the classic inflammatory arthritis. You can see that there's some quote-unquote fusiform swelling of the digits. You can see there's the knuckles here are inflamed with synovitis. If you pressed on these knuckles, they'll feel boggy, almost mushy, like a soft cushion or jello. And the patient will complain of pain. So the antibodies to look for are listed here in the chart on the right. JO1 is the typical classic board question, probably easy to order on the floors. It's an antibody to the tRNA synthetase, and this is why this is called anti-synthetase syndrome. All these antibodies are to the tRNA of the cell. JO1 is the most common, and that has a classic presentation, like we said, of arthritis, Raynaud's, mechanics hands. 50% of patients can have Raynaud's. And these are some of the other antibodies: PL7, PL12, OJE, JKS, YRSO. It goes on and on. The list is quite extensive with anti-synthetase antibodies. And you can see each of these antibodies has a particular association with some other manifestation, such as pulmonary hypertension or esophageal dysphagia involvement, ILD, even dermato features, or UIP, NSIP on interstitial lung disease. So these are all things to look for. Now, this is very common here in our clinics. A lot of these patients test positive for one of these other anti-synthetase antibodies. One that's not listed here, but we do see often, is something called the Rho52 antibody, and that has many of these patients in our clinic have these features. The next category of myositis is overlap syndromes. So basically, overlap is what it sounds like. It's an underlying autoimmune disease, such as rheumatoid, or a patient who has rheumatoid or lupus or Sjogren's or systemic sclerosis, in addition to myositis. So here in this case, for example, some of these overlap diseases have their own antibodies as well that are detected on a myositis panel. For example, the anti-PM-SCL antibody. These patients have characteristic features of myositis, plus Raynaud's, plus inflammatory arthritis and scleroderma features, such as thickening of the skin, telangiectasias, girder dysphagia, interstitial lung disease, and these patients are sometimes treated as a scleroderma myositis overlap, depending on what is a predominant symptom. The other overlap syndrome that we sometimes see is called mixed connective tissue disease, which in this case, the antibody is against anti-RNP. So just as a general rule, the patients with overlap syndromes, as some other overlapping disease that is occurring with the myositis, have less extensive muscle involvement, lower CK levels, or even normal CK levels compared to classic polymyositis, dermatomyositis. But that doesn't mean they don't have myositis or myalgias or motor weakness. And this is something that can be elicited and better understood. So what are the things to ask for when you get a patient on the floors or you see a patient in the office? One is to ask about muscle weakness and the time length and that has been going on, whether it's insidious or acute onset. Typically in myositis, it's going on for weeks to months. Sometimes a patient can't really, you'll notice a lot of these patients, not only because of the language barrier, but even just simply providing a history. A patient living their day-to-day may not be so in tune with their weakness. They just say, I feel weak, doctor, or, I can't do what I'm doing before. I just feel tired. You'll get other vague terms like I hurt, I'm in pain, I'm just fatigued, I'm not able to work out at the gym like before. I can't, go up the stairs. And it's not very clear, are these patients short of breath and that's why they can't go up the stairs, or they can't physically lift their legs up the stairs? So you really sort of need to elicit that in a history and ask them, sort of break it down for them. For example, are you able to lift your legs and climb up a set of stairs? Are you able to get off a chair and a sofa in a low toilet seat, or do you have to push yourself off with your hands? Are you able to carry groceries and objects? Are you able to hold up your arms? How many weights are you lifting at the gym now compared to before? We once had a case, unfortunately, he did pass away, but he used to be a bodybuilder and he had pictures of himself and he used to box. And now when you looked at him, he was cachectic and he had no muscle mass. So that was a big difference. No one would have believed it if he hadn't shown me a picture of himself, just a few years earlier. And he was a terrible historian and totally non-compliant, which is just me justifying why he didn't do well, unfortunately, to be honest. But for him, it was at every visit trying to quantify and qualify what he was and not able to do at home, in addition to if he was taking his medications. So what are the exam findings to look for? One is the motor exam. You really need to spend your time checking the proximal and distal extremities. You need to do finger clasp sometimes for these patients if you're suspecting IBM, inclusion myositis. You have to look at wasting of the muscles on exam. You need to undress them. It takes some time, but an initial exam can really help you, especially the skin. So sometimes patients don't even realize they have rashes, or they forget they have rashes. So you do need to check the proximal thighs, check the knuckles, ask for photosensitivity, look for the V-neck, look for the shawl sign, ask them if their orbits are swollen in the morning when they wake up. In the summertime, do they get rashes across their face when they're exposed to the sun? And you have to look at their hands. Sometimes patients will not realize, or they say, my hands always look like this, but you look at them and they're puffy, or they have whitening or thickening of the skin. These are all things to look for. You want to do a lung exam. Sometimes you'll hear crackles at the bases. There was one patient who was a kind of a stumped case because the antibodies weren't very helpful, and she was complaining of some weakness, and she had some big rashes, and she was denying respiratory symptoms, although she looked sort of winded under her COVID mask. And when we listened to her lung exam, she did have Velcro crackle sounds at her bases, and we referred her to pulmonary, and she looked totally fine. She denied respiratory symptoms. X-ray was normal, but we still, I still felt like there was a high risk of the myositis and some interstitial lung disease. We got a CAT scan, and it did confirm interstitial lung disease early on. So that kind of guided her treatment plan and her therapy. And she did become symptomatic, but it improved with treatment. So this is some things you should screen for on your exam and check for. And then Raynaud's is something you may just need to sort of show a picture to your patient. They may not understand it when you explain to them. You do your fingers turn red, white, blue on cold exposure. But if you show them a picture on your laptop or your computer at the desk, then they have a better sense of, oh yeah, that happens to me. And then they'll show it to you. So these are some of the things I was telling you. Here we have mechanic's hands. These are the Gottron's papules. Here's the V-neck shawl sign, the periorbital heliotrope rash with violaceous hue, and a malar rash as well. The holster sign on the right, on the lower right with the legs. We had a patient like this admitted a few months ago as well. Two patients actually like this. Calcinosis cutis, which is your calcium deposition on the distal fingertips. And these are gross nail fold changes you can see with periangular erythema, which is seen in Raynaud's. So what test do you want to send off? Well, one is a CK. You want to monitor the CK serially, especially if it's elevated. You want to assess the response to treatment. And sometimes for possible relapse, you'll see that the muscle enzyme goes up as muscle breaks down. And like I told you, the CK is not the end-all be-all. It can be normal, or it can be 10 times the upper limit of normal, depending on which myositis we're considering. LDH, aldolase, and even liver enzymes sometimes are a clue. Let's say you get a patient with motor weakness. Comprehensives are often done by the PCP sent, if the patient is sent to you, but sometimes a CK is not done. But a cheap, easy, quick thing to look for might be, you might see that there's some transaminitis there, and then you can go ahead and order a CK or an aldolase to check. And then inflammatory markers, an elevated SAD rate or CRP, especially if there's intense inflammation or skin rashes or muscle breakdown. And serologies, like I said, in ANA can be positive in 60% of patients. The next thing you want to order based on your suspicion is a myositis panel. Depending on where you're located on the floors, we guys ask you to do a downtime form for an extended myositis panel, which, as you know, takes anywhere between 2 to 4 weeks to come back. But sometimes we can't wait for that. We have a patient in the ICU with acute onset respiratory failure and motor weakness, and we think they have myositis. They could have a typical dermatomyositis rash, and they're on the ventilator. We don't wait for the antibodies to come back. We sort of treat them and pulse them with the steroids. But this is something that, we ask that you guys send off. So what are the antibodies that are checked for? I kind of already explained those, to kind of touch base on about the different antibodies with you. And the myositis panel here checks off a lot of these, along with a few others I'm going to talk about later. Like I said, the Jo1 is the most common antibody. It's present in about 20% of myositis patients with these features, and then these are the other antibodies listed. So just a brief overview on antibodies. I'm not going to go into this in too much detail. There's a lot of data coming out, a lot of literature coming out in terms of myositis and the clinical relevance of these antibodies. But I do want you to take away the key point here is that, you know, the reason we keep nagging you to send off that panel is because the presence and type of the antibody can sometimes clue you in on which features this patient is likely to develop down the road and what else to look for. So for example, here on the right, you can see MI2, NIXP2, MDA5, TIF1 gamma, SAE. These are present in adult dermatomyositis. The antisynthetase and MDA5 antibodies have a high association with interstitial lung disease, which is important because you may need to look for pulmonary fibrosis or ILD, and that may guide your treatment. Also, they may hint at pulmonary artery hypertension, and that may guide your treatment. For example, the other antibodies here to look for TIF1 gamma and NIXP2 have a association with malignancy. So you have to screen these patients with myositis for malignancy because sometimes a malignancy is a driving factor for their inflammation. And you can pound them with steroids and chemotherapy, but if there's an underlying pro-inflammatory state here or driver, such as an underlying malignancy, that's the key to the treatment and important to diagnose. And then, for example, statins, like I mentioned, is the HMG-CoA reductase antibody. So these are some of the things to look for. Just briefly, what are the key antibodies? I kind of mentioned some of them to you. SRP, which is present in 5% of patients with myositis, MI2, which is associated with dermatomyositis, MDA5, which is a high association with ILD, and skin findings, NIXP2, which is a very high association with malignancy, and also juvenile dermatomyositis. TIF1 gamma also has a high association with malignancy and has characteristic skin findings. SAE2 has a high association with dysphagia and GI issues. Some of these we did have a patient a few months ago with severe esophageal dysmotility, perforation, gastritis, large bowel obstruction, had a PEG, was on TPN on and off, was very cachectic, and she had SAE antibody. And HMG-CoA reductase, which is associated with statin myopathy. And then the row 52 antibody, as I mentioned to you, SSA, SSP, Smith, RNP, these are associated with the overlap syndromes. And PMSCL, which I mentioned, is associated with scleroderma features. So aside from antibodies and blood tests, what else can you do? An EMG. So electromyography is helpful to distinguish myopathic changes from neuropathic causes of motor weakness, such as myasthenia gravis or motor neuron disease or neuropathy. You can also use the EMG to target which muscle sites are involved and help locate where you can do the biopsy. You don't want to do the biopsy on the same side you did the EMG, by the way, because they'll be affected. You want to do the contralateral side, assuming it's the same symmetric weakness that's going on. But just briefly in the insert, you can see that neurogenic lesions are manifesting differently on an EMG in terms of their activity and motor unit potentials compared to myogenic lesions. The second thing you can do is imaging. So MRIs are great. Sometimes you can pick up muscle inflammation, edema that is indicative of active myositis, fibrosis, and calcification on an MRI. And it has to be done with the right sequence. So you do want to alert the radiologist, or at least when you place your study, you want to put in your impression of what you're looking for so that the study can be protocoled properly. For example, the T1 weighted images can look for atrophy and fibrosis of the muscle, whereas the fat-suppressed T2 and the stir images can help look for active disease, muscle inflammation, and can guide where to target the muscle biopsy. Just so you know, sometimes we get consults for an incidental finding of quote-unquote myositis read by the radiologist on an MRI done on the floors, and a patient is admitted for sepsis or cellulitis or something else. You have to understand, myositis can be due to any of these other things, like infection or rhabdo or metabolic myopathy, or they could be in the ICU, they could be deconditioned. So just because an MRI picks up an incidental finding of myositis, you really have to put in all those other clinical cues I discussed previously in terms of the history, the exam, the antibodies, to sort of get a sense if this myositis found on imaging is a true inflammatory autoimmune myositis or not. The other way to diagnose would be skin biopsy or muscle biopsy. So skin biopsy is helpful when the rash is not so obvious or can overlap with some other autoimmune diseases. We know lupus causes rashes, Sjogren's causes rashes. So if a patient has some kind of vague rashes, but you're not sure if it's dermatomyositis or some lupus myositis, for example, you can get a skin biopsy. And a muscle biopsy is also, like I said, helpful in differentiating the different types of myositis. You typically want to go for the quadriceps, deltoid, or biceps. You don't want to go for the weakest muscle because it'll be atrophied and there won't be much inflammation there for the pathologist to diagnose. And you don't want to go where you did the EMG. The MRI can sort of guide where you want to do the biopsy, which is another reason to get it, in terms of identifying the active or involved muscle. Again, a muscle biopsy is not mandatory as part of the clinical criteria or diagnosis of myositis. If it's pretty obvious with dermato, they have pretty classic skin findings, and they have proximal muscle weakness and elevated CK, you don't really need a muscle biopsy. You can begin treatment. And the same thing with antisynthetase syndrome. If you have a pretty specific antibody like the Jo1 and they have muscle weakness and they have some of the other features like brain nodes or lung disease, then you don't need a muscle biopsy in that case. So what are the things to look for in muscle biopsy, like I briefly mentioned before? Things are muscle fiber necrosis, degeneration, regeneration, inflammatory cell infiltrate. So dermatomyositis, like I mentioned, is more perivesicular perimysial infiltration with CD4 cells, whereas polymyositis is with more endomysial inflammation with CD8 positive cells. Inclusion body myositis has more rimmed vacuoles with Congo red staining. These are buzzwords, by the way, for the boards. And immune-mediated necrotizing myopathy has necrosis. So these are the original classification criteria of Bowen and Peter in 1975, which list the key findings. Classification criteria were very simple back then, by the way, in my opinion. Only 5 things. Nowadays, you'll see that there's 100 things in the guidelines and criteria before you can make somebody, you can give somebody a diagnosis. But basically, these are the key components of a diagnosis. 1 is symmetrical weakness of the limb girdle muscles. 2 is a positive muscle biopsy. 3 is elevation or abnormal enzymes. 4 is the EMG findings. And 5 is characteristic rashes. Those are all the things we were just talking about. The new criteria also are more outlined and more detailed. You can look at this article, which I've referenced here, but this is just a brief algorithm if you're sort of kind of trying to figure out what does somebody have based on their age. Is it juvenile or is it adult onset? Yes, kids do get all rheumatologic conditions. Kids do get dermatomyositis and myositis, by the way. And then you want to look at, do they have a rash? Yes or no. If it's a rash, then it's probably dermato. If it's not, then you have to figure out what the muscle biopsy looks like and which muscles are involved. And then this is very simplistic, but basically, is it polymyositis or inclusion body myositis? So what's the management? It depends on the type of myositis and which organs are involved, from skin to lungs to heart, etc. Also, the severity of symptoms and the presence of other causes that could be driving myositis, such as malignancy. You also have to sometimes discuss goals of care. I think we had a patient with biopsy-proven myositis a few months ago who was 96 years old, deconditioned, bedbound, with several other comorbidities. At that point, I think you have to sort of sit down and discuss it with the family and the patient. Are you going to be pulsing this person with steroids? Do you really expect them to get up out of the bed and start walking? These are some things to think about. So inclusion body myositis has a poor response to steroids, by the way, but sometimes we do throw the kitchen sink at these people when we don't have an alternative. And typically, the treatment course is steroids and a steroid-sparing agent, of which the category and list of options is quite extensive, but these are the recommended ones, including methotrexate, mycophenolate mofetil, azathioprine, and rituximab. IVIG is also sometimes used in myositis. It has some data, and topicals and corticosteroids can also be used for the skin findings. The presence of the other organs involved, as I mentioned, are important to address and have to be treated individually. If there's interstitial lung disease, as can be seen on a CAT scan, what are the key findings in CAT scans that you may see on a high-resolution CT? You can see granulous opacities, you can see consolidations, you can see NSIP pattern or UIP pattern, and sometimes there may just be some aspiration pneumonia due to dysphagia, esophageal dysmotility. The CAT scan may even be able to read something like a patulous esophagus, which is a sort of a way of seeing that there's esophageal dysmotility without having to do GI studies. So these are some things you can look for in a CAT scan. You may see some effusions, pleural and pericardial effusions, that can also be helpful. In terms of esophageal disease, you can do an EGD. You may see some gastritis, esophagitis, motility and swallowing studies are helpful, as well as bowel studies. For cardiac disease, you can do echo and check for conduction defects. Cardiac MRIs are helpful for infiltrative cardiac disease as well. As you can see, in rheumatology, we really depend and collaborate with many of the other specialties, including dermatology, GI, pulmonary, cardio, as well as neuro, to help manage and treat and monitor these patients. Screening is key. For myositis in particular, you may have heard that all autoimmune diseases have an increased predisposition to underlying malignancy or risk of developing malignancy over time compared to the general population. This is particularly true for myositis. Breast, gyne, GU are high risk, as well as GI. So it's very important for these patients to have their annual skin exam, to have their colonoscopy when they're due, to have their GYN, their mammo, etc. screened for. And oftentimes you'll see that there's an association that can be picked up either one preceding the myositis or a few months or a few years into the diagnosis of the myositis. So some masqueraders, what to look for. The rheumatologic ones I'll talk about in the next slide, but there are every other organ system or some other causes of myositis. Masqueraders include endocrinologic, as we know, thyroid disease, hematologic, such as amyloid myopathy or paraneoplastic, endocrine, as in diabetes, as I mentioned, neurologic, motor neuron diseases, drug-induced, we talked about briefly about those, such as steroid myopathy, and infections such as HIV myopathy, which may be tricky to diagnose. And I remember there was one case presentation at our annual conference about a patient with trichinosis of myositis, and that was picked up on a biopsy. Some drugs that commonly cause myositis, we mentioned the statins, steroids, as well as drugs of abuse, alcohol myopathy, and rhabdomyolysis can also occur. Some of the this is tricky and this is interesting. Hydroxychloroquine, which we use for a lot of our autoimmune conditions, has also been reported to cause myopathy and myositis, something to look for and consider, and some of the other tubular drugs. So polymyalgia rheumatica is not myositis. It's not actual breakdown, infiltration, and inflammation in the muscle, but rather it's a normal muscle biopsy. And this is really based more on history, normal CK levels, elevated ESR-CRP, elderly patient with proximal upper and lower muscle weakness, stiffness, not weakness, stiffness, aches and pains, fatigue, weight loss, malaise, B symptoms, kind of, if you were to think per se. They don't have the characteristic rashes, and they don't really have any antibodies otherwise. That is a classic case for PMR, also important not to miss because it has high association with giant cell arteritis or temporal arteritis, vasculitis, blindness, some things to look for. This is very different from myositis. The other thing that we come across in rheumatology is fibromyalgia, which is chronic widespread diffuse pain with other associated symptoms from head to toe, including fatigue, cognitive issues, and psychiatric issues, GI issues. Again, this is a negative pathology, negative muscle. There's no weakness per se. Patients are able to perform their ADLs. And it's important to know a patient with myositis may also have fibromyalgia. These things are not exclusive. It can overlap. So this is just a reference article that you guys can read about, and also some of the resources I mentioned previously at the American College of Rheumatology, in case you're kind of stumped or you want to think about what else I can send or who I can get involved. These are some resources to look for.